So, Cora, let me get back to you. Andrew mentioned something, and I think Evan brought it up again, which has to do with, when we look at the population, we probably would expect a lot of those patients who have maybe metastatic disease with a better scan, with PET scans, right? And I think, maybe we were or have been a little bit behind some of other areas of the world where actually PSMA PET has been used routinely as being cost effective, and I think we're getting there. And I think in this recurrence setting, I think most of us are currently using PSMA PET. So some would argue that, you know what, we're moving this agent early, and if I see metastatic disease, they are hormone sensitive, we would still use data, extrapolating data from ARCHES or ENZAMET, and so they're still, regardless of seeing metastatic disease, some would say, I would still consider enzalutamide in this setting, even if the PET is positive. All of this to ask you, is that your approach? When you have a patient who is PET positive, CT scan negative, conventional scan negative, is that your approach, or how you approach that patient?
In our hospital, it's been fairly easy to get a PSMA PET, which is not true all over the world, not even in Germany where they use it a lot. We heard that today. So we do PSMA PET. But if there's absolutely nothing on conventional imaging, I think we have to take that into account as well. And I think that there can be mistakes if you just take the PSMA PET. And sometimes PSMA PET can show up other things. It can show up other diseases. It can show up benign diseases. And I think it's an important thing to know that. If the PSMA PET is positive in many places, we often will do biopsies to see what we're doing with interventional radiology. Again, I work in an academic center where I have all that available. I think most people who work in the community don't have the access to the PSMA PET. And the EMBARK study was not done with PSMA PET. It was done with conventional imaging. We have to remember that too.
Great. Do you both agree, Andrew?
Yeah, I would say it is a more small volume disease, where the goal of many patients is to not have continuous therapy forever. And so I think if you can get to a point where you can stop therapy and enjoy a year or 2 or 3 off therapy, some of the strategies to have that prolonged break are doublet therapy. When you just use enza monotherapy, your testosterone is very high, so as soon as you release them from enza, there's a very short time before that PSA goes right back up again. But if you're on doublet therapy, there's about 21 months of remission. Other strategies are metastasis-directed therapy. Some people employ that to delay ADT, but you could also employ it, a lot of the EXTEND study or the STAMPEDE-2 study, trying to destroy those micrometastatic sites, combine that with best systemic therapy, but then stop the best systemic therapy so you can get a very long off period.
I like that EXTEND study very much, where patients have oligometastatic disease, and we give SBRT to those sites, and then we treat them with combination therapy for 6 months and then stop. Right. It's different than the EMBARK study.
Right, wonderful. Evan?
I like playing devil's advocate, so I'm going to say something that might be controversial, but I don't get PSMA PET on everyone in this disease state.
It's okay.
So here's what I do in advance. I have the discussion with the patient about what I would do with the PSMA PET. If it showed this, I might consider that. If the patient says, I don't like that and I would never consider it, and I can already reach for systemic therapy with androgen deprivation therapy and enzalutamide in this setting, then what do I need to find a couple extra metastases for on PSMA PET? Now, if the patient says, I know there's data to show that metastasis-direct therapy can kick the can down the road until I have to start androgen deprivation therapy, and I've heard these terrible things about the androgen deprivation therapy side effects, and they're interested in that, then that would be a good reason to get it. But it's the good old thing you learn in med school where it's like, don't get a test unless you know you're going to do something with it. Yeah. If you get a test and you just see it there and then you put them on androgen deprivation therapy and enzalutamide, at this point in time, I don't know that I needed to get that PSMA PET. So,
right.
Yeah.
So final point or question for you guys before we kind of close this section. Wonderful discussion. So based on this data, does any of you considering still ADT alone?
Absolutely. I mean, ADT alone has less toxicity. I think regardless of your decision, you need to maintain a survivorship-focused approach. Where you're mitigating adverse events, cardiovascular, bone health, encouraging exercise. These men are living a decade or more, on or off ADT, plus or minus Enza, and there's a lot of comorbidity that goes with that. So home blood pressure monitoring, encouraging an exercise program, monitoring bone health. There's some men that are just not candidates for a doublet therapy because of those comorbidities. And ADT, it's been practiced for many, many years with decades of survival. So it is appropriate for some men.